Despite optimal guideline-based treatment, patients with chronic heart failure have a substantial risk of death or heart failure hospitalization after a recent worsening heart failure event. Vericiguat is a novel guanylate cyclase stimulator which directly enhances the cyclic GMP pathway. Diminished nitric oxide and decreased GC activity are both hallmarks of heart failure, precipitated by endothelial dysfunction and oxidative stress. Deficiency in GC-derived GMP causes myocardial dysfunction and impaired vasotone regulation. Vericiguat directly stimulates the soluble GC and produces GMP. It also restores nitric oxide sensitivity. The Victoria study assessed the efficacy and safety of vericiguat. The primary composite outcome was cardiovascular death or first heart failure hospitalization. The inclusion criteria included patients with chronic heart failure, NYHA class 2 to 4, ejection fraction less than 45%, and on guideline-based therapies. They also had to have had a worsening heart failure event and an elevated BMP. Key exclusion criteria included being on a long-acting nitrate, awaiting heart failure transplantation, or having severe renal, liver, or lung disease. Patients were randomized to vericiguat or placebo, and a stepwise increase of the dose of vericiguat to the target of 10 milligrams. So who made it into the study? The average age was 67 years old, 24% were women, 2/3 had a recent hospitalization within 3 months, the rest had a hospitalization within the past 6 months or recent need for IV diuretics. The average ejection fraction was 29%, most were class 3 to 4 heart failure, 90% of patients were on dual guideline-based therapies, with 60% being on triple guideline-based therapies. 30% had an ICD or biventricular pacemaker. And now for the results. With the cumulative event rate on the vertical axis, you can see a high event rate in the placebo arm. And now for the vericiguat curve, you can see a relative risk reduction of 10% with a p-value of 0.019. This translates into an absolute event reduction of 4.2 per 100 patient years. Notice the curve separate at around 3 months. There was heterogeneity in the subgroups of age greater than or less than 75 and the degree of BMP elevation. There was no heterogeneity based on geography, index event, class of heart failure, or use of sacubitril/valsartan, or EGFR. Overall, the serious event rates were similar. Symptomatic hypotension, syncope, and anemia were more common with vericiguat. There was, however, no effect on electrolytes or renal function. So in summary, vericiguat was significantly more effective than placebo in reducing the composite endpoint of cardiovascular death or heart failure hospitalization. There was no statistically significant effect on cardiovascular death or all-cause mortality. There was heterogeneity in NT-proBNP quartile subgroups, which is the subject of ongoing investigation. Overall, vericiguat was generally safe and well tolerated. Because vericiguat is a once-a-day, easy-to-titrate, generally safe and well-tolerated medication, without the need of monitoring renal function or electrolytes, it may play a useful role in patients with a recent worsening heart failure event.